15 minutes and you measure it to see how much tear production there is. On the bottom left, that's the show test. So the show test is going to be a finger prick test, which basically use the blood of the patient and then you put it on the paper and send the paper over to the lab, and that will help diagnose Sjogren's syndrome. On the top right, you have a test called Inflammadry, which is going to measure the tear osmolarity and help diagnose, dry eye, help diagnose inflammation on the surface of the eye. So very useful. And what's good about Inflammadry is you can actually, start a treatment and then measure the osmolarity after your treatment and then monitor how it's going. And on the bottom right, you have the Schirmer test. And the Schirmer test is kind of a standard test that everybody knows about for testing dry eye. And again, the basal tears will, after 10 minutes, you'll be able to measure it and see. So the mainstay of treatment for aqueous deficient dry eye is punctal occlusion and also artificial tears. Obviously, when we talk about artificial tears, we are encouraging preservative-free artificial tears, and then punctal occlusion. So this is the basic, and everybody should be doing this for aqueous deficient dry eye. But let's talk about scleral lenses. So scleral lenses, the scleral lens is designed in a way to vault over the cornea and land gently on the conjunctiva or the conjunctiva overlying the sclera, okay? And so what we're doing is we're filling this lens with saline solution, and when fit properly, as you can see on the top left, that OCT image, you can see that the lens is not touching the surface of the eye at any point. And there's a tear film reservoir there between the lens and the surface of the eye. That tear film reservoir actually provides hydration and lubrication to the ocular surface, to the cornea, the entire time it's being worn. So it is an oasis. It's like providing an oasis for the eye, and as long as the scleral lens is being worn, it's giving that oasis. And so the goal of this type of treatment is to restore the ocular surface, is to help it heal, to protect it from the outside environment, to protect it from microorganisms, to protect it from the friction of the blink. So the scleral lens serves a lot of purposes in protecting the ocular surface and helping it restore itself. So we can see here that original photo that I showed after wearing a scleral lens for a couple of weeks, a significantly improved ocular surface. So this is an amazing treatment that we can use now in severe ocular surface disease. And obviously there are many different ones: Stevens-Johnson syndrome, Sjogren's syndrome, graft versus host disease, just regular dry eye, aqueous deficient, evaporative dry eye, exposure keratopathy, neurotrophic keratitis. These are just a few examples. So let's go through some cases that are interesting. This is a case of iatrogenic dry eye syndrome. So a 52-year-old white male presented to the office and he had a bone marrow transplant, and he developed ocular graft versus host disease. So off the bat, you can see at his initial examination, he's got a lot of staining. And this is lissamine green staining once again. So you can see a lot of staining of the ocular surface. You can see staining of the conjunctiva in all quadrants. So let's talk about ocular graft versus host disease. So to understand this, we really have to understand inflammation. So we're not really sure what the pathogenesis is. It's poorly understood, but we know that donor-derived alloreactive T lymphocytes play a pivotal role in the development of graft versus host disease. So what you have is aberrant proliferation of autoreactive T, predominantly CD4 plus and Th2, and also B cells and autoantibody formation. So basically this involves both cell-mediated and humoral immunity, and you have infiltration and inflammation of the lacrimal gland, conjunctiva, and ocular surface. So basically we're having an activation of the T cells, which causes severe amount of inflammation. Inflammation can eventually cause a decrease in the density of conjunctival goblet cells, as well as scarring of the lacrimal gland and the conjunctiva. So actually, if you look at a patient with ocular graft versus host disease, you won't really find a drier eye. This is the driest eye you can really come up with. So you can see here, we put this patient in a scleral lens. Obviously the eye still looks a little bit red, but what we're hoping is that the patient feels better, and also that we protect and restore the ocular surface. So the patient's vision wasn't too bad. It was really just extremely dry. And in these cases, you really want to go for a larger diameter type of scleral lens. So the larger the diameter is, the more of the surface we can cover, and the greater your oasis is. And so a lot of these patients will opt for the 18, 19 millimeter, 20 millimeter, 21 millimeter lenses. And again, the bigger it is, the more surface we can cover. So that's just an example. Another case of iatrogenic dry eye syndrome. This is a 19-year-old female who developed Stevens-Johnson syndrome at a very young age as a result of a reaction to children's Motrin. And she's failed with every kind of scleral lens. I mean, you can see how scarred her eye is. She had a lot of symblepharon. So symblepharon, again, is the basically scarring between the conjunctival and bulbar conjunctiva, which makes it very hard to fit any type of contact lens on this. So she really doesn't have a lot of vision. You can see with the scleral lenses that we fit her with, which I'll show you in a minute, she's hand motion in the right eye, light perception in the left. But it's important to put patients like this in a scleral lens, even though the vision is not that great. And the reason you want to is actually to prevent further symblepharon formation. So remember that patients with Stevens-Johnson syndrome do not have any limbal stem cells. Okay, they're not having a re-epithelialization of the ocular surface. And there's scarring, and the scarring is constant. It's a progressive scarring of the ocular surface. So what you're doing with the scleral lens, in addition to slightly improving the vision in this case, is you're really preventing symblepharon formation. So we did fit this patient with an Iprint Pro, which is an impression-based scleral lens. You can see how hard it was for us to put that impression material in the eye. And when looking at the impression, you can see all those bumps. So the impression is supposed to look very smooth, and you can see how irregular it looks. And that's because of all the scarring that you have on the ocular surface. But this is really what the patient needed. So let's talk about exposure keratopathy. This is a 4-year-old Hispanic female from Puerto Rico. She was born with a condition called Manitoba oculotrichoanal mota bifid nose. So she was diagnosed with bilateral acquired infantile corneal opacities of mild density, which were occluding the visual axis. They were caused by exposure. So the scarring that she had was caused by just the eyelid constantly being open. And she's got congenital upper eyelid colobomas in both eyes. So she obviously has an incomplete blink, and she cannot close her eye completely, okay, because of the coloboma, the eyelid coloboma. She's had several reconstructive surgeries, and she's followed closely by oculoplastic surgeons here in Bascom Palmer Eye Institute. And she's got really high refractive errors as well. She's got irregular astigmatism, obviously, because of the scarring that she has in the corneal opacities. And, you know, she definitely has amblyopia. So you can see her visual acuity there, 2150 in the right eye. And so the reason why we would want to fit a scleral lens in this case are multiple, right? So you really want to provide the oasis for the ocular surface by, you know, protecting it, because the eye is so exposed, right? She can't close her eyes. She's got this exposure. She's got colobomas. So we're trying to protect the ocular surface from the environment, from infection, from drying, and we can do that with the scleral lens. Okay, but also she's got amblyopia. She's got irregular astigmatism. So we're actually neutralizing that irregular astigmatism with the scleral lens. So we've got protection, and we've also got improvement of vision and correction of amblyopia. And that's the goal. So you can see the lens on her eye. So this is we had to make the diameter a little bit smaller than an adult lens. We use a 14 in this case. And, you know, obviously the parents were very involved in application and removal training, and also, you know, but now she does it every day. She's super happy. You can see a photo of her and I there on the right side. And this is, you know, photos of her in Miami visiting us, and those are photos of her mom and I, and her and her mom. So that pretty much concludes my part on kicking off this specialty lens. There's a lot of interesting cases. There's a lot of interesting things that we can do. Some hot topics I'm excited to learn about are myopia management, scleral lenses at front, you know, front surface correction of aberration, higher order aberrations. And again, thank you for allowing me to kick off this session, and I would like to open it for questions.
Well, thank you, Elise. It was really wonderful. You covered the whole gamut of specialty lenses and very interesting topics. I am sure people are interested, but they may be a little shy to start with. But the floor is open. Anybody have any questions? Please come forward. Any questions? Somebody has to start first question, then people feel yes. So, Elise, you talked about this dry eye treatments, which are very recently started in the US. I don't think we have EpiFlow and other stuff in India. Dr. Maskati?
We do have all the treatments available. We have LipiFlow with us, and we have IPL, which is another way of stimulating the meibomian glands to improve tear secretion.